first words are to thank Professor Nessn to come here to Portugal, to have the opportunity to share with us your preliminary results of the trial. I think this solution trial that can help us dealing with these patients that have a long survival and a long follow-up period. And we believe that with the results we can change the way we can do our practice, easing the burden that we usually have in our consultations regarding non-invasive bladder cancer. I will also thank Uromonitor to support this meeting. And finally, I would like to thank the administration of Prof Azawi hospital to host this session here in this place. So when we prepared this session, we thought it would be interesting, before Professor Nessn start to present the results, we will do a snapshot of the epidemiology of bladder cancer in Portugal in order to illustrate the importance of this topic of changing the surveillance of these patients. So here we have some charts from the World Health Organization, and here just to say that, as you all know, this is a frequent disease among the world cancers. Of course, we know that is more frequent in more developed countries, but we also have high numbers of bladder cancer in less developed countries. And these numbers of incidence are increasing within those countries. Here we have also from the Global CAN, the World Health Organization, we have a prediction of the incidence of the bladder cancer for the next years. This is a prediction of an increase in the incidence of this type of cancer. Of course, this is worldwide data, and we believe that this increase is more related to the developing countries, since in more developed countries nowadays we have a stable disease, and in some countries we have a decrease in the incidence because of the epidemic of the tobacco exposure that is decreasing in most developed countries. And so a few years ago, I think 2 or 3 years ago, we did a study with one of our master students trying to describe the trends of bladder cancer frequency in Portugal, and we used data from our national cancer registries and also data from the Portuguese National Institute of Statistics, trying to assess the dimension in terms of epidemiology of this problem in Portugal. And here we have crude data, so we have the crude number of new cases of bladder cancer in Portugal here in this chart, both for men and for women, and we have the crude incidence rate. And what we can see is that in a qualitative analysis, just looking at the chart, that we have a trend towards an increase of the incidence during the study period that we have data from the cancer registries. When we analyze the mortality, we have a large number of years to analyze, and we also observe an increase in the mortality both for men and for women. But we decided to do a more detailed analysis using the joint point analysis, trying to identify trends regarding the incidence and mortality. And here we have data of the incidence, so this red line, and what we can see is that among the male, we observed a statistical significant increase in age standardized incidence rate between the period 1997 to 2005, and then we have what we call stable incidence. When we look at women, we have for the whole studied period a statistical significant increase in the incidence in Portugal. We did the same analysis for mortality, estimating the annual percentage change, and among men there was the mortality was stable in the first period, and then we observed an increase in the last years between 2005 and 2018. Among women, there were no statistical significant differences in mortality regarding the entire period. We also analyzed in this way certified by different regions of Portugal using the regional cancer registries, and we observed that in the Açores and in the central region of Portugal there were no difference during the entire period, but regarding the incidence. But in the north of Portugal, we have in the first period of analysis an increase in the incidence, but in the final period, 2005-2010, there was a statistically significant decrease in the incidence of bladder cancer. In the south, during the entire period, we observed an increase in the incidence. This is among men. Among women, we only observed a statistically significant increase in the incidence in the south, and there were no difference in the other places of Portugal. We also tried to analyze this in a more detailed way in Portugal. An analysis stratified by districts, which is one of our administrative divisions of our country. And what we can say is that, of course, the crude number of new cases is higher in the places we have more population, such as in Porto, Lisboa, and Setúbal and Braga. Okay, but when we estimate the incidence, the standardized incidence rate, what we observed, there was a trend that to higher levels of incidence in the south of Portugal. Okay, we don't have much explanations to this. Probably it can be related to the tobacco exposure. There are some works talking about the consumption of tap water and the use of triallomethanes that can be a risk factor for bladder cancer. And we know from other studies that we perform that in the south of Portugal we have higher levels, higher median levels of triallomethanes in the south region of Portugal, but this is it's not final data, so we have to have more mature results to present this. But in the map in the right, we performed an analysis that was trying to identify the places in Portugal that the incidence changed during the period 2006 and to 2010. And what we observed that in almost every place in Portugal there was not a change, but in the north of Portugal, in Porto and Viana do Castelo, there was a statistically significant decrease in the incidence. And the only place, the only district with a statistically significant increase was in the Castelo Branco. In the last part of this work was trying to compare what we observe in Portugal to other countries that are similar to us with the same level of development. And what we can see is that in Portugal, as I stated before, we have a trend towards an increase in the incidence, and we have other countries in Europe showing the same, but we have other ones that are nowadays, or in the last decades, the results show a decrease in the incidence. But the most worrying results of this study was when we compare the mortality among the several countries, because Portugal is probably the only country in Europe, or one of the countries, especially in the most recent years, that is increasing the mortality. Okay, since we know that the incidence is slightly increasing, but we have a more increase in the mortality, probably it means that the survival is not so good as we would expect in this disease. Okay, so this is much different from other countries, as you can see here in the right chart. We addressed also how was the net survival, 5-year net survival of bladder cancer in Portugal. We only have data from the North Portugal because it was the only cancer registry that had data of 4 cohorts of patients regarding the 5-year net survival, and the results show that more or less we have a 5-year 70% survival of these patients. I don't know if it's much different from Denmark, but it's our results. So since we have a stable incidence in several countries in Europe, and we observe a decrease in mortality, this means that we have higher levels of surviving patients with bladder cancer. So the prevalent bladder cancers is increasing, which means that we have more patients in our consultations in the health system that we have to do surveillance. That's why it's relevant to have new tools in order to ease the way we do the surveillance and to decrease the burden of that surveillance programs in the whole health system. Okay. There is here a chart also from the World Health Organization showing in Portugal what is the weight of the incidence of some of the most frequent cancers, and the bladder is in the 6th position. However, if we analyze the prevalence instead of the incidence, is in the 4th place. So it means that it's the 4th most frequent cancer among the cancer survivors. Okay, so this is relevant data. There is an interesting paper published, I think almost 10 years ago, trying to analyze the economic burden of this disease across European Union. And to resume the results, it shows that several countries have a high burden of costs, not only regarding the healthcare costs, but also what we call indirect costs concerning the productivity losses such as mortality and morbidity. So this is a cancer with a lot of costs, and it's another issue that will highlight and stress the importance of having a good surveillance programs. So we believe that what Professor Nessn will present will help trying to decrease this important burden for the healthcare system. In Portugal, comparing to other countries, we don't spend too much money for each bladder cancer patient in comparison, for example, to France, Netherlands, and United Kingdom. But the absolute level of the costs we spend is still too high for the health system. So I think this is a good snapshot to introduce what Professor Nessn will share with us. Thank you. If you need help changing the presentation,
I don't know. Do I have to do it?
I can help you if you need. Okay.
Yes. Thank you for the invitation and thank you for the presentation. My name is Dr. Azawi. I am Associated Professor at Zeeland University Hospital. This is our coming hospital, and I am Associated Professor at Copenhagen University. Actually, we are working on solution trials since 2019. We perform the trial at our hospital in Zeeland University Hospital, and this is my lab team. And the other hospital is Aarhus University Hospital, led by Professor Uromonitor, and this is his lab team. Conflict of interest, unfortunately, I know. I will speak very brief about the epidemiology of the bladder cancer. We all together know that the bladder cancer is the second most common cancer in the men. 380,000 new cases per year, 150,000 deaths per year globally. 75% of the cases are men between the 50th and the 80th years. 75% of the of these cases are non-muscle invasive. Of them, 20 to 30% PT1, and about 10% is carcinoma in situ. Bladder cancer is the most expensive cancer disease in terms of cost per patient. Cost per patient from diagnosis to the death, it is about 96,000 to 187,000 US dollar. So it is very expensive disease among another cancer patients. We do the surveillance program in Denmark a little bit different from the recommended from the European urology. When it is low or intermediate risk group, we're doing the 4, 8, 12-month follow-up. The European urology recommended every 3 months. By this program, actually we save one control per year. But we making the control or the surveillance for every 12 months for 5 years. If there is any recurrences, so we have to start the follow-up program again by 4, 8, 12. In our hospital, the last year we performed 845 cystoscopies only for the surveillance. In Denmark, at 2020, we have 2,314 bladder cancer patients new diagnosed. Of them, 1,200 patients with the PTA low grade or if we're looking for this 1,200 patients, each patient will undergoing at least 7 to 8 cystoscopies within the next 5 years. So it is a lot. In our solution trials, we focusing on PTA low grade or Belvis grade 1 or 2. The aim of the study to evaluate the potential clinical impact of Uromonitor test regarding possible reduction in the number of cystoscopies without increase the risk of progression by evaluating the sensitivity and the specificity, and this is the primary endpoint. The secondary endpoint to understand the meaning of positive and negative Uromonitor test in results of cystoscopies in the opposite. So we would like to find out if the Uromonitor is positive and the cystoscope is negative, what will happen after 2 years? We don't have the result today, but we have the results of the primary endpoint. Some background about, short background about the genetic evaluating for the Uromonitor. The presence of the somatic mutation in the promote TRT gene in different types of cancer. In the bladder cancer, these somatic changes show prevalence up to 85%, along with FGFR3 mutation at codons 248 and 249 represented the most robust biomarker for bladder cancer. And this is what we are looking for in the Uromonitor. We designed the study as multi-center, prospective, observational clinical trial. We invite all patients diagnosed with the PTA low-grade bladder cancer within the last 2 years to participate in the study. Patients underwent neoadjuvant chemotherapy, patients with metastatic disease, patients received installation therapy within the last 4 weeks, and patients with the carcinoma in situ excluded from the study. The results of Uromonitor test are blinded to the clinical staff, and the result of the cystoscopies are blinded to the laboratory staff. We calculate the sample size by this way that we estimate the sensitivity of the Uromonitor by the 75% and the specificity for 75%. We estimated the recurrence rate for the PTA low grade about 22 to 25% within the first 2 years, and the study power to estimate change in the sensitivity by 20% and change in the specificity by 10% confidence interval with a minimum 30 events within 24 months. So by this way, we need about 160 patients to complete the trial. If the patient is newly diagnosed with PTA low-grade bladder cancer, the first control, as I mentioned, it is about 4 months, so they will come to the 4-month cystoscopy, Uromonitor, 8-month cystoscopy, Uromonitor, 12-month cystoscopy, Uromonitor, 16 and 20-month only Uromonitor, 24-month cystoscopy and Uromonitor. If the patient's coming previously diagnosed with the bladder cancer, PTA, low grade, it will coming only 3 times to the cystoscopy and the Uromonitor, and the rest of the time it is coming only to the Uromonitor. And this is to find out the secondary endpoint. We start at May 2019, and 6 months after we start, we being restricted by the COVID epidemiology, so we don't have the ability to invite the patient to the hospitals. So we decide to make the home test or test home. I don't know what we have to call it, but we make some instruction for the patients how to collect the urine sample and filter the urine sample by themselves. We make a video for them if they don't, if they cannot read the instructions, how to make the filtration of the sample. And actually, we don't have any patients that will not accept participate in the study or continue participating in the study. It is very easy way to get the urine sample from the patient by this way. We already did 250 tests by home test. At the end, until today, we have 196 patients included in the study. 32 patients, we don't have the result for the cystoscopies yet, because it is blinded, so that's why every hospital have to send me the result of the cystoscopy, and Uromonitor company have to send me the result of the Uromonitor, and I will put it to the third party to make the analysis. We have 18 patients, the urine was invalid, and this is maybe because of the storage, the conductions, or something happening with the urine, but it is bad quality urine we get. 3 patients, actually, they have always positive Uromonitor. And after 4 months, they have positive Uromonitor. After 8 months, they have positive Uromonitor, and all the cystoscopies was negative. After about 12 months, these patients developed hematuria, and we discovered upper urinary tract tumor, PTA low grade, in all these 3 patients. So I exclude them from the study because it is one of the exclusion criteria for this trial. So at the end, we have 143 patients in our institute that I am presenting the result for them. This is the distribution of the patients with the visit 1, visit 2, 3, 4. So we need about 100 patients to finish the last visit. The mean age of the patient is about 69 years, and there was 64 males, and the recurrent rate was 27%, and it is very important that is fitting the international recurrence rate. When we are looking at the time of the inclusion, we had 143 patients, only 17 patients they have 2 positive recurrences. At all, we have performed 332 cystoscopies in this period, altogether had Uromonitor test, and there is only 39% true positive. In the whole trial, we performed 686 Uromonitor tests. Of these, we had 68 positive Uromonitor tests. These patients not altogether undergoing cystoscopies. We had 68 patients with the positive cystoscopy. Altogether underwent 2RP, and only 39 patients had true positive. 29 patients with no tumor on the histopathology. And this lead to the positive predictive value of the cystoscopy. In this study, it was 57%. It is very low. When we are looking for the results of this study, at the inclusion time, 143 patients underwent Uromonitor test and cystoscopies. We did not miss any patients in the first, at the inclusion time. All the Uromonitor tests positive, they was positive in the cystoscopy. True positive, histological verified. This leads to negative predictive value of 100%. When we're looking for the 332 tests that altogether underwent cystoscopies in this 143 patients, we missed actually only 5 patients, and this lead to negative predictive value of 98%, and the sensitivity it is very high, 87, and the specificity it is 97%. This is in 332 patient cystoscopies. In conclusion, Uromonitor test presenting high sensitivity and specificity rate in the real-world follow-up program. We can already see that we can change the surveillance if we make Uromonitor test every 4 to 6 months and cystoscopies every 2 years. So by this way, we can reduce the number of the cystoscopies at least 50%. Thank you. Any question? Of course, yes.
I'm not going into the bladder because to leave room for more expert people on the audience.
Not going into the bladder, but it was very impressive to have these 3 upper tract cases detected by Uromonitor. So would you think this is an indication that the test, we could run a trial on the test for use in surveillance or diagnostics of upper tract tumors?
Unfortunately, I have to see no, because the Uromonitor it is developed through the surveillance, not through the detection. So we don't know the prevalence of the Uromonitor results in the detection at the diagnostic time. Maybe in the surveillance for the upper tract urinary cancer, yes, maybe, because the nature of the tumor is the same. But at the diagnostic time, I don't know what is the results.
Yeah, but upper tract is like another indication that we could do studies on.
Exactly, because how to collect the urine sample, how much we have to collect, how to keep it is different from the bladder cancer. And again, the test, it is designed for the surveillance and not for the diagnosis.
Congratulations, I loved the presentation, and I work a lot with bladder cancer, and these results are quite impressive because I've studied a bit of biomarkers, and this is really impressive if it confirms. My question is, in the study design you only use low risk tumors, right?
Low grade.
Low grade, okay.
Yes, because it is low risk and intermediate risk.
Low, intermediate,
Yes.
okay. My other question is regarding your follow-up protocol.
Yes.
Because I follow up the protocol of the EAU guidelines, and if for the low risk, for instance, you do a cystoscopy at 3 months, and then another one at 12 months, and then you do once a year.
Yes.
My question is, with this monitor, what is the advantage? My point is, probably this study would be much better with the higher risk and intermediate risk groups, and then it would really prove its real value.
I would make, if you ask me how to make the surveillance in the PTA low grade, regardless if they are low risk or intermediate risk, I will do the first control by the cystoscopy to be sure that we not lead tumor, and then 2 year and 2 year. So we have at all about 3 cystoscopies, and normally we have 7 to 8.
Still, are you planning to do this in the high-risk patient?
This study is designed for the low risk. Sorry, for the
Low
low
grade.
and intermediate risk.
Because of the FGFR part.
Yes.
Okay.
We can try it, but we decided from the beginning to make the focus of the trial to catch the PTA low grade. And PTA low grade, we know very well, it is the low risk and the intermediate risk. But for the PTA high grade, we did not include them in this study.
My other question is regarding the specificity, where the most problematic confounders that we have in cystoscopies are BPH and urinary infection.
Yes.
How was this regarded when doing the study or not?
We do always the urine test because before we making the Uromonitor, except when we do the home test. We take everything and we don't know the results of the urinary infection.
Of course, this wants to show what is real life and not lab real life, of course.
Exactly, that's what I am saying. This is a real life, that it is a specialist doing the cystoscopy, it is a resident doing the cystoscopy, it is the real life world.
Right.
So congratulations again for the promising results. As my colleague said, you restricted your sample to tumors of low risk and intermediate risk. I think from our clinical experience, we have most of the patients in the high risk, and those that have a high burden of usage of healthcare resources. That's why we think that probably that population will benefit more from a urinary biomarker instead of low risk population. Do you think that if we design a trial to address the high risk population, we can decrease what is the pattern of follow-up that the EU guidelines recommend, which is 3 months cystoscopy plus cytology?
I believe we have to make a new trial for the high grade, and this is the very important point, that we have to divide the bladder cancer, because the high grade it is different from the low grade. For the high grade, it is very dangerous disease. The progression is very high. We have to be cautious about the results of any test, any biomarker. And the only reason we did not include high grade in this trial, actually, because we have we had another trials with the high-grade patients, so we could not include them in the study. That's why we divide the high grade and the low grade, because we have another trials with the Professor Urinary Biomarkers on the August. They're doing the high grade with the expert. But of course, we can do the same design for the high grade. Every time patients coming to the cystoscope, we can take the urine test and test it and find out what is the reaction of the Uromonitor test. But very important, we don't have to mix everything together. Low grade is low grade and high grade tumor is high grade.
Okay. Another question. When we do the follow-up of this kind of patients with non-muscle invasive bladder cancer, we are always concerned about the recurrence or metachronous lesion in the upper tract. That's why we, once a year, or depends on the protocol, we do an image of the upper tract, usually a CT. Do you think that using those 3 cases, I know that there are only 3 cases that you reported here, that the cystoscopy did not identify anything, and the problem was an upper tract tumor, that in the near future we can change the way we do the protocols for the upper tract, and we can only use, for example, cystoscopy plus Uromonitor, and we don't have to do an image of the upper tract?
Actually, in our surveillance, we don't do any CT scannings in the beginning because they have hematuria. We catch the bladder cancer, any kind of the bladder cancer, so we do the CT urography in the beginning. But if it is clear, so we will not do any image in the future, except they get a new hematuria condition. Okay. Yes, if we have the results of Uromonitor for the upper urinary tract, so maybe we can add it. The problem we have only 1 trials on the upper urinary tract with the Uromonitor, and we have to wait for the result to find out what is the sensitivity and the specificity for the Uromonitor for the upper tract. Before this, I don't know actually what is the sensitivity of this. Yes, if it is very good as what we have here, of course, we don't have to make the CT urography, and we're coming to save a lot of patients, because we all together know the disease in the upper tract is more dangerous than in the bladder. About 75% of this urethral tumor, it is invasive.
Yes, sure. Okay. Just a final question. In another setting, here we are discussing the surveillance, but if we are thinking about, for example, screening high-risk populations, such as those that have smoking habits from a long time ago and have a high risk of developing a bladder cancer, do you think in the near future we can use this tool as a screening tool? For example, like we use a low radiation CT scan for lung cancer for those patients that have high risk of lung cancer because they were smokers for a long time?
I think we have to add P53 to the test, because as I mentioned before, Uromonitor test designed for the surveillance is not designed for the diagnosis, and we don't know the difference. But I think if we add P53 to the test, maybe we can use it for the diagnosis. Actually, I already have 42 patients perform Uromonitor test for the diagnosis issue. I don't have the result yet, but we try to find out where we are. It is not designed for this, but we do the standard investigation for all these patients, plus Uromonitor beside it. As I said, I don't have the final result, but it will come. I am not sure it is very good like this, but I believe if we can add P53 to the test, so we come to be very close to the screening test.
Okay, thank you.
As I understood, you're also testing for the high-grade tumors, right?
Not Uromonitor.
Yeah, but another
test.
which genes are being evaluated?
We're using the expert actually for the high risk patients.
Yeah, but the expert is already available,
Yes.
commercially available.
Yes, but we use it for the only in the research, not as
Okay.
as a normal.
So I'm just imagining in the future that Uromonitor is a success, and then the expert is another success. If I go to my hospital administration to say to the low risk patients I have this test, to the medium risk I have this one, and to high risk tests I have this one, what do you think it would be the reception of our administration?
If you say to them in another way, because they don't know what is this test and the other test, if you say to them, I will save you $3 million per year, so they will be very happy for you. So
can we guarantee that?
With this result for the Uromonitor, only in my hospital, we're doing about 800 cystoscopies per year. If I remove 400 patients from my hospital, it is cost us about 5,600 Danish crown. It is about $800 to make the cystoscopy. If we remove $800 multiplied by 400, so it is a lot of money to get the administration in our hospital so online.
Congratulations with your presentation, and thank you so much for being coming to Portugal finally. I just have a little question, and it's probably a bit pertinent, but you mentioned in your presentation almost at the end that you envision that a test such as Uromonitor will reduce the cystoscopies for at least 50%. We all know that the gold standards and the guidelines, they say the gold standard is doing a cystoscopy. And my question is, do you, how convinced are you that the biomarkers such as Uromonitor will one day replace and will become the gold standard for the follow-up of bladder cancer? Or you think that it will always be a tool used to reduce the frequency that the patient has to go the cystoscopy? Or do you envision that it will be the gold standard for treatment?
This is maybe a hope I have, but I believe if we invest more in these biomarkers altogether, I am not speaking about Uromonitor, expert, CX, CRS, and there is many biomarkers. If we make a good investigations and investment in these biomarkers, maybe after 5-10 years, we don't need for the cystoscope. But we have to be more sure. We have to be sure that we not increase the risk of the progression. When we get this point, so I believe we can escape this. There is many cancers, melanoma, lung cancer, they're going very far in this matter. The bladder cancer, we just started in the last maybe 5 years with the biomarkers, and I believe in the next 5-10 years, the biomarkers will change the rules.